Thank you for the interesting topic. I was wondering, you said before we give Q fever vaccine, we do the serology and skin testing. Because as a GP, I've never done skin testing, so I wonder whether we'll be doing right job or who should be doing it, and how do you do it?
So what happens is you purchase from CSL a product called Q Fever Skin Test Antigen. Just comes in a little vial. There's 0.5 of an ml in it, and you've got to dilute it 1 in 15. So that means you need 14.5 mLs of saline for injection, and you've got to mix the two together, which is you can usually do in one syringe. Okay, so you've got the 0.5 of the skin test reagent plus 14.5 mils of saline for injection, mix them together, and then you take 0.1 of that, 0.1, a very small amount. So that's why it's a good idea to do several patients at the same time. And you inject it into the skin intradermally, and you put the needle in at a very acute angle. And as it goes into the skin, you have to see a little bleb come up. That means you've done it properly. If you go too deep, there's no bleb, and that's a subcutaneous injection, and you won't be able to feel the lump. You see, 7 days later, you've got to run your finger across and feel where there's a little lump there. And that's due to T cell lymphocytes being attracted to the site if they've already pre-sensitized to Coxiella boniti antigen, you see. So they just come there. They think the body's being attacked, so they go there, and then you can actually detect them as a little lump.
So we
also,
need the microphone.
sorry, just also in addition to that, if you just chat with the Seqirus staff, they've got some training modules and some training programs that GPs can access. All right, and that will show you this whole process.
And just before you ask that, I've got a question online for Stephen. Stephen, why do you think it is that long COVID isn't recognised, or why is the funding falling off? Is it because the authorities don't believe that there is such a disease, and are we still being hoaxed into thinking there is such a thing as long COVID?
Well, firstly, I don't think it's a hoax. My experience and also the research indicates that it's real. And this is a great question because it's sort of about politics. What's happening is that the state governments don't want to take on the responsibility of that in public hospitals. So they're not putting money into it. And the federal government feels that all the funding should be going to general practitioners. But it's a very complex disease, and like any complex disease, you want to be able to refer them into a specialist review. With them being multidisciplinary, it's probably better to have a multidisciplinary centralised clinic, at least 1 or 2 per state. So that battle is being undertaken at political levels, and so that's one of the reasons that the funding is dropping off. In the UK, what's happening is the funding is now morphed because there's so many people with it, is morphed, and the multidisciplinary long COVID clinics are now handling any post-viral fatigue. So that may be an option in Australia, but at the moment, it's simply the fact of our split health system.
Immunisation will take that up as a political challenge. We've got a question from the floor here, but thank you. You need to talk to the microphone so the online audience can hear the question. Thank you.
You mentioned about the skin test, but is it not much simpler if we do the serology and check for the IgG?
So this is a
And
question
is
to
it
Stephen
cheaper as well?
about the skin
So
test.
the question is the skin test different to the serology for IgG? Is that what you're asking?
Because we need to do the test before we give the QVAX.
That's right.
So isn't it much more simpler if we send the patient off for a blood test rather than do all those steps?
Oh, I see what you're saying. Why do we have to do both? The question is, why do we have to do the skin test and the blood test? Well, the blood test measures antibodies, IgM and IgG, which are part of the humoral immunity to the patient, and the skin test measures the T cell or cell-mediated immunity, and they're 2 separate parts of the immune system, and you have to make sure that both are non-functional in that patient, otherwise they'll get a bad reaction to the vaccine.
So you couldn't do a blood test, and if that's negative, then do the skin test. I think that's where the question is going.
So can't we just
we
cannot just rely on the serology, and then if it's
positive,
negative?
You could do that, yes. You could do the serology first, and that come back positive. You don't have to do the skin test, but you can't do the skin test first because that will stimulate positive antibodies, you see. So the serology could be done first and then the skin test, but not the other way around. But really, the most simple thing is to just do them both at the same time, because you'll get results 1 week later and then you vaccinate the patient, because the vaccination is what the patient wants, because they're going into a risky situation. So rather than drag it on for 2 or 3 weeks doing them in series, if you do the things in parallel, you'll get a faster result.
Okay, thank you.
So Angela, there was a question online. So if you give a 4-month injection at 5 months, is that an error because the computer said no?
If you give a 4-month-old an injection at 5 months, it's 4 weeks overdue for its 4-month-olds, potentially. Absolutely not an error. We'd be praising the provider for catching the child up and not letting them go longer than 4 weeks overdue.
Yeah, thank you.
Yeah.
Question from the floor.
Yeah, hello. I've got 2 questions. If a person had an acute infection, how long after can they have the
So
vaccination?
that's acute fever. Yeah.
And another one is what happens, how do we treat children under 12? We normally don't give
The first
doxycycline.
question is someone's already got an intercurrent infection. Well, you probably can give QVAX. It's never been tested, I have to say. But going back to first principles, you probably can give QVAX because it's a killed vaccine. So different components of the immune system will react and they will develop immunity. But you don't give living vaccines like MMR. You don't give living vaccines if someone's got another infection going on, because you'll get a suboptimal response. And now I forgot what the second question was, sorry.
For children, how do we treat
Our
children?
children under 12, yes. Well, the vaccine's only registered for 15 and over, and that's because it was tested in adults to be for abattoir workers. But I've given it to children under 12, and it works perfectly well. They don't have any more side effects than anyone else. So if it's an off-label use, and only a doctor who's willing to do it will do it. So a lot of doctors won't do it, of course. So, but it's not dangerous. I've immunised my own children, because when I was working in the laboratory, I was scared I was going to bring it home on my clothes and infect my children. So I vaccinated my own children. I think they were 6 and 8 or something like that. But you've got to do the skin test and the blood test, though. And Seqirus won't support you. If you use it in under 15, it's not registered for use under 15.
I think the question is, how do we treat the child?
So you need to talk these questions online. Remember, we've got doctors online, and
I think we give Bactrim for the kids, I think.
Oh, how to treat. Sorry, I thought you were talking about vaccination. My apologies. Well, look, I'm not an expert in that. You can give doxycycline to children. There's a big, people go on about it, but it's actually perfectly safe. The other drugs you could use are things like azithromycin. In pregnant women, you use cotrimoxazole, but doxycycline is by far the best. And this all is in all the books now, you know, that it's perfectly okay to give doxycycline to children.
Stephen, a question to you. The cardiac manifestations of long COVID, is that a vascular response or a cardiac response? And the POTS that you talked about, is that because of the vascular damage that's causing that, or is it a vagal nerve?
We don't have much evidence for vascular damage of the heart. We do see pericarditis, which is an autoantibody response, and the effects on the heart rhythm is probably through the vagus nerve, which is quite often, particularly in autopsy victims, autopsy samples have been shown to be teeming with a virus. So we actually think it's a neural response. The areas where we see problems with the vasculature is mostly in the small veins in the lungs, and that's why we've done, for chest pain, we always do a VQ scan, because the CTPAs only see the large vasculature, and quite often we've seen little showers of small clots in the periphery.
Wasn't there some early there's a question about MRI changes from long COVID in like multi sort of brain infarcts or demyelination? Any comments on that?
Yeah, so we've got at St Vincent's, we were very lucky to get some funding to follow about 128 people with acute COVID, and we followed them very closely for 3 years. Many of them have, with cognitive impairment, have had MRIs and functional tests. So firstly, the cognitive impairment in this group seems to follow anosmia very closely, and also abnormal results on MOCA or RUDAS and other more complicated cognitive testing. What we've seen is a breakdown in the blood-brain barrier in two areas, one in the frontal lobes and one around the hippocampi. We think the frontal lobes is due to the virus traveling up the olfactory nerves, and the areas around the hippocampus we feel is due to direct effects on the blood-brain barrier. Bruce Brew has discovered a change in the quinolonic acid levels in the brain, which is a neurotransmitter, in those complaining of cognitive impairment. And we're now seeking funding to trial some medications for it.
Okay, Angela, a question, then another one from the floor. What's the commonest vaccine error, do you think?
I think probably, can I have a couple? I think giving the wrong vaccine and giving an expired vaccine and a vaccine that's been compromised from cold chain would be the top three.
And one of the difficulties is that's why you say check with your local authorities to see whether the compromise is a significant one and it alters the effectiveness of it. Because sometimes technically it's out of range, but doesn't necessarily damage the vaccine. So there's some studies on that you need to check in.
Correct. The state and territory health departments have received documentation from the various vaccine manufacturers. It's commercial in confidence, so the state health departments cannot release you the data, but they have all been given the stability data of every single vaccine. Every single vaccine is probably different to what their tolerability is for excursions over 8 degrees. But as we know, most vaccines become frozen if they are stored less than 0 degrees.
Yeah, so that comes in when the power goes out on Saturday afternoon and you don't find it until Monday, work out whether your fridge actually sitting at 9 degrees compromise them or not. It's important to know what's in there and check. And sometimes it hasn't, but you need to check. So on the floor here. Yeah.
Yeah, Dr. Leong is the name here, GP in Sydney. I suppose my question is to Stephen Foh. There's been recent reports that there's been an increased incidence or presentations to emergencies with chest pain since COVID. And obviously the anti-vaxxers will say, look, it's vaccine related. And then, but we don't really know. So what are the answers to that? Is that due to the COVID vaccines? Is it due to increased clotting due to COVID infections? Is it actually due to the vaccine's side effects? How do we answer that difficult question?
Well, I think firstly, if anyone's had COVID, we know from epidemiological studies that their cardiovascular risk increases by about 50% for the next 12 months. The second thing is that there is some side effect of the mRNA vaccines in young adult males that can give them a pericarditis and a myocarditis. That's exceptionally rare. I mean, it's less than 1 in 100,000. So that's a possible risk factor in that group. The other thing that we find as part of long COVID is chest pain from a variety of factors. Often, sometimes it's pericarditis and responds to colchicine or analgesia. Sometimes it's neuropathic pain and it responds to anti-neuropathic pain medications. But we haven't seen, I think you can rest people's minds that the vaccination is not causing vascular events in the heart. And I certainly, I'm not an expert on vaccine-related side effects. I'm simply reading from the research on the mRNA vaccination in a small group of young men. This was a particular of particular interest prior to the Olympics, when a lot of our athletes who were young men who were concerned about getting COVID vaccines because of that side effect. So it was quite extensively discussed, and the risks are very, very low.
Another question from a couple of questions from the floor, and then we'll head off to lunch. So on the floor.
Thanks, Stephen, for a great talk. You did touch on CPR and biomarkers in long COVID. I'm just wondering, have you been able to identify any predictors that would predict those who would develop long COVID?
You mean, well, we do know that people with D dimers that don't drop and CRPs that are high have a higher risk of long COVID. We've just looked at a marker for cognitive impairment, which is this quinolinic acid, but it's not available yet. It's therapeutic. If there are people who get COVID who are immunocompromised, we do the nucleocapsid antibodies, and we do quantitative measures to work out when they're less likely to be infective, and also when they're more likely to have recovered from the acute event. So the short answer is there a predictor? Is there a blood test that predicts whether you're going to have long COVID? The answer is no. There are some blood tests that will give you increased risk of developing long COVID, which is one of them is prolonged CPR and the other one is prolonged raised D-dimer.
And any predictions of ethnic association with increased risk of long COVID?
No, there's a gender risk. I mean, women are more likely to get it, and people in their working age are more likely to get it, and those with multiple comorbidities, obesity, hypertension, diabetes, and those who've been had the disease very severely with a lot of risk factors, and indeed those who've been hospitalised. Those tend to be the most common risk factors.
Thank you. And one from the floor before we go to lunch.
This
Thank
is
you.
for Angela. If immunisations are given early, and I'm just speaking of the 6 weeks, the 4 months and the 6 months, are they considered to be an error, and how early can they be given?
It does depend on the vaccine. We go by when the vaccine has been registered and licensed for use in Australia, number one. So has it been given prior to that age or not? It will depend on the vaccine itself in regards to rotavirus vaccines, for example. If they are given outside of the window of opportunity to give dose 1 and dose 2, then we should not proceed. But we've seen certainly some AIR reports suggesting that 2-year-olds have been given oral rotavirus vaccine. So it's about, making sure that you're using those dosage wheels, etc. If vaccines are given a little bit too early, so just because the parent presents a little bit before 4 months of age, we may not be observing the minimum intervals required between all of the different antigens that they received at 6 weeks. So we've got to be really careful that we don't vaccinate too early because of those minimum intervals. We would rather vaccinate a week late than a week early.